to truly cure this genetic disease, try to correct the underlying genetic change with new technologies. It's really exciting to think that we might be at a point in the not too distant future where we can actually start to manage these genetic conditions by actually correcting the underlying genetic cause.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. Thanks for tuning in on another Monday. My guest on today's show has been a Parallax guest before. She educated us about hypertrophic cardiomyopathy, and this is in continuation with a mini-series we broadcasted earlier on Parallax. My guest is Dr. Carolyn Ho. She is professor of medicine at Harvard Medical School. She is the medical director of the Cardiovascular Genetics Program at Brigham and Women's Hospital in Boston, Massachusetts. And our topic of discussion today is genetic approaches to hypertrophic cardiomyopathy, from genotype to precision therapeutics. Dr. Ho, thank you so much for doing this for us today, and welcome back to Parallax.
Great. Thank you so much. It's wonderful to be back.
Yeah, no, it's great to have you back. And, we certainly have this very nuanced and focused topic. And, we know that you're the world expert at this. So I'm going to start this episode by asking you about the, certainly, for our listenership and hypertrophic cardiomyopathy is not an alien word for this listenership. Why do you think and I know it's a genetically inherited cardiomyopathy, tell us more about why you think it's important to have genetic testing in a disease state like HCM.
Genetic testing really allows us to better understand the etiology or the underlying cause of our patient's HCM. In combination with taking a very careful family history that extends back or spans 3 generations, genetic testing can give us a shot at identifying the exact genetic cause of HCM. And this can give us new insights into why our patients have developed disease. It can give us some insights onto prognosis, because in general, patients with sarcomeric HCM, or HCM that's caused by dominantly acting sarcomere gene variants, this is the most common genetic cause of HCM, have a worse overall prognosis than those who have genetically elusive HCM. So if you compare individuals that have had genetic testing and have positive versus negative results, those with positive results or those with sarcomeric HCM tend to have earlier onset and more prevalent instances of atrial fibrillation, ventricular arrhythmias, symptomatic heart failure, and slightly greater mortality. And then genetic testing can also give us really valuable information in guiding the care of the family. Because these are genetic diseases that have either a strong or a more weakly acting genetic component. If we can identify a strong dominantly acting genetic variant in a patient, then we can have great guidance for managing their family. Without this information, we counsel that their first degree, while they're failing in general, is at risk for developing HCM, and their first degree relatives should have longitudinal screening periodically. But if we are able to identify the exact genetic cause, we can definitively identify those relatives who are at risk for developing HCM by virtue of having inherited that genetic cause, or who are not at risk for developing HCM because they did not inherit that genetic cause. And we can focus longitudinal follow-up only on those that have inherited the failing genetic variant.
That is insightful. So my question to you is, and this is from when I was seeing patients in clinic with Dr. Marin, when I was a fellow, this is a decade ago. It's an autosomal dominant disease. There is variable penetrance, and there are some patients who are healthy to begin with. There's a family history of hypertrophic cardiomyopathy. So, for example, a mother or a father gets diagnosed with hypertrophic cardiomyopathy, and we recommend genetic testing to them. And then we say, do make sure that your siblings are aware of this diagnosis, and make sure that your kids or your children get tested. Are we testing children? Are we doing genetic testing in children as well? That is my first question. And the second question is there, I know for siblings, for older adults, you just want them to get a screening echocardiogram to begin with. Do they get genetic testing as well? And for kids, it's the same question. The only question is there an age cutoff to get the first echocardiogram?
You would do genetic testing on individuals that have a clear diagnosis of HCM. And then you would do, what we would refer to as diagnostic genetic testing. And you only have to do this once in a family. So you would ideally want to identify the individual in the family that has the most definitive diagnosis and the most severe form of disease, and initiate this diagnostic genetic testing on them. And that's genetic testing that is typically a panel of, usually about 50 or 60 genes that have been associated with HCM. And, the genetic sequence of all of those genes will be identified. We're most likely to find interpretable results in the 8 core sarcomere genes, but, the panels tend to be much bigger than that. And if a genetic change is identified, a pathogenic or likely pathogenic genetic change identified in that first family member that went forward for the diagnostic genetic testing, then predictive or variant confirmation genetic testing can be offered to any family member regardless of age. So it can be done in children. We can use saliva samples rather than blood samples on anybody, and saliva is much more friendly for children. And if the parents are very eager to know whether that child is or is not at risk for developing HCM, that would be the predictive or confirmatory genetic testing would be a good way to determine that. If children are older, we would want them to participate in the decision making as well, to state whether they were or not interested in getting that information on themselves, and genetic testing could be carried out. You would not want to initiate diagnostic genetic testing on individuals that do not have a clear diagnosis of HCM, because even within families with a very strong family history of autosomal dominant disease, only half the family members on average are going to be at risk. So if you do diagnostic testing, that big broad gene panel testing on an individual that does not have clinical HCM, then it'd be very difficult to interpret the results. If you had a negative result come back, you wouldn't know if it was negative because the family member does not carry the family's variant, or it was negative because the individual simply did not inherit. Or it was negative because the family does not have a defined variant. So you really want to start with somebody that has clinically obvious definitive disease.
Yes. So, in patients who I'm going to ask you 2 examples here, and these are examples I've encountered in my own clinical practice. I took care of a family in Ohio where the mom had manifest disease. She had obstructive hypertrophic cardiomyopathy and had septal myectomy, had mitral valve repair, had atrial fibrillation. I offered genetic testing to the mother, and it was positive for a sarcomeric mutation. She has 2 daughters. One at the time was an athlete and taking part in competitive athletics. She had preponderance of ventricular ectopics, did not have manifest phenotypic disease. we obtained genetic testing in her, which came back positive. And then she had her sibling, which we offered genetic testing, but for one reason or the other, she did not get the genetic testing done. However, there was nothing on transthoracic echocardiograms for both of them. How would you manage this family, Dr. Ho?
So the daughter that's been identified to be definitively at risk, by virtue of having inherited the mom's genetic variant, should be followed serially. So, like during adolescence, we would recommend uh, doing echoes and EKGs on roughly a yearly basis, and that should probably continue on that cadence through the 20s, and because she is at risk for developing HCM. Like you said, HCM has variable penetrance. If penetrance is age dependent, so it's unusual to see uh, penetrant, clinical disease in young children. We can see it, but it's quite rare. Disease tends to develop in early adulthood, through the 30s, is the most common time for people to develop HCM. But roughly 30 to 40% of people who have inherited a pathogenic variant won't ever develop HCM. They'll be non-penetrant. We cannot identify those people prospectively to figure out, who is going to develop disease and who isn't. So we had to follow all at-risk variant carriers serially, over time. The daughter that hasn't been genetically tested yet, has a 50-50 chance of having inherited on the variant. So 50% chance that she inherited the variant, 50% chance that she didn't. If she does not wish to have genetic testing, then she should be followed clinically, the same as her definitively at-risk genotype positive sister, because we don't know which group she falls in. We would want, and then you would default on just treating her as if she were at risk. But if she were to get testing or found not to carry the variant, then she would not need to have proscribed serial follow up.
Fantastic. Are there any interventions, any medical interventions that can be offered to patients like these?
Yeah. So disease modifying therapy, has been a a strongly sought after goal for a long time, because we have, with these genetic diseases, we have a real luxury of being able to identify individuals who are at high risk for developing disease, because they carry a disease causing genetic change, but years ahead of when disease actually develops. So there really is, an incredible opportunity to initiate disease modifying therapy at those early stages before uh, s- uh, um, permanent remodeling has occurred and before adverse consequences has been suffered. But it's really hard to do that. I spent a lot of time in my career trying to do that, and it's really challenging for many reasons. Two big reasons are because it's really hard to see if you've made these people better, because they by definition don't have clinically overt disease, and the early phenotypic manifestations are really quite subtle and change over a long period of time. So you need a lot of people that you follow for a long period of time to try to determine if your treatment, which was intended to either slow down or prevent disease progression, has worked. It's pretty straightforward to show that you've made a really sick person a little bit better, but to show that you've made somebody that is, essentially quite well a little bit better, is a lot harder. And second, these phenotypic changes, these metrics of disease progression are subtle, often intranormal, and take place over a long period of time. So again, this kind of scale and scope of the studies that you would need are, somewhat daunting. And also the duration of time that you need to follow somebody is really quite long to test whether the treatment really has had an effect. We had an attempt at disease-modifying therapy with the VANISH HCM trial, which we conducted a couple of years ago. And in that study, I targeted individuals with what we defined as early sarcomeric HCM. So these were relatively young individuals. The mean age of the trial was about 23 and a half years. They all carried a pathogenic or likely pathogenic sarcomere variant for HCM, but they were relatively early in their disease because they, were young. They hadn't had disease for a long time. They didn't have severe remodeling. The maximum LV wall thickness had to be less than 25 millimeters. They were asymptomatic and YHA1 for the most part, and really didn't have any clinical events or limiting symptoms. So we treated them with valsartan or placebo for a period of 2 years, and we knew that we couldn't have the study endpoints be, usual clinical endpoints because we wouldn't anticipate that they would develop any clinical outcomes over that, the 2 year period of treatment. So we really focused on seeing if valsartan could change, some of the underlying structure and function of the heart that would point towards slowing disease progression. So we looked at a bunch of features that are known to be abnormal or can be abnormal in individuals with sarcomere mutations before they develop HCM. So we looked at E prime velocities. We looked at, to see whether they had small LV cavities. We looked at LV cavity size. We looked at LV walk thickness. We looked at cardiac biomarkers, including NT-proBNP and troponin. We integrated all of these into a composite Z-score so that an increase in the Z-score would indicate improvement in cardiac remodeling. So either no progression or an improvement in some of the abnormal features, and a decrease in the Z-score would indicate adverse remodeling or continued disease progression. And valsartan did seem like it was able to slow disease progression to some extent. Those people that were randomized to valsartan had a higher Z-score than those who were randomized to placebo, suggesting that there was slower or improved remodeling in those on valsartan and some worsening of remodeling on those on placebo. So that was encouraging. And the updated guidelines for HCM management in 2024 to have this as a 2B recommendation that, if you have an individual with early sarcomeric HCM that would fit VANISH criteria, you could consider offering them valsartan as potential disease modifying therapy. It's low cost, quite safe. There's little downside, but at the same time, VANISH wasn't designed to answer the most important clinical questions that we have and that our patients have. Whether it's going to improve long-term outcomes, such as decreasing the likelihood of atrial fibrillation or ventricular arrhythmias, or heart failure symptoms. We weren't able to test that, so we don't have those answers yet.
Yeah, no, that's phenomenal work. How many of these patients do you see in your practice? I mean, as in, you see these patients and there is no clinically manifest disease, and these patients are relatively younger, and you have the discussion of starting a medication like valsartan, which we know is a benign medication from our experience with the medication in patients with, either heart failure with reduced ejection fraction or preserved ejection fraction or even hypertension. Are these patients normotensive? Are they apprehensive starting this medication?
Right. So the interesting things about a lot of our hypertensive drugs is that they may not change blood pressure that much in people that don't have hypertension. So we're very careful about that in VANISH, and so we, of course, weren't sure what dose to use. This was based on mouse models of HCM where losartan was used and shown to attenuate phenotypic progression and an HCM sarcomere mutation mouse model. But it's very hard to figure out dose equivalents from mouse to human. So we don't want to, take a risk of underdosing patients. So we picked a target dose of the highest FDA approved dose. Either we had a mixture of adult and pediatric patients. So, that was the target dose. And all patients had to go through an active run in to make sure that they would tolerate titration up to the to the target dose without difficulty before they were randomized. And we had very few people that could not make it through the active run. And so even in some of our, young, slim women that typically have pretty low blood pressure at baseline, they were able to tolerate titration up to target dose. So you want to do it carefully. Make sure the last thing we want to do is make anybody feel worse. But most people are able to tolerate titration to 320 milligrams of valsartan.
In terms of future therapies, in patients like these where they have the gene. I mean, I'm talking futuristic here, but do you see a role of something like CRISPR, where we can eliminate the gene which causes the disease?
Yeah. So the future is now. It turns out there are actually there's a lot of interest and activity in the gene modifying space right now for HCM, and there are a couple of genetic therapy trials that are ongoing. There's one that is targeting patients with truncating variants in myosin binding protein C, where we believe that disease HCM is caused by people not producing enough normal myosin binding protein C, because they have one normal allele that's inherited from the healthy parents and one allele that uh, um, does not actually code a functional protein, because there's a truncation in the gene that's inherited from the affected parent. So overall, all we believe that HCM is caused because not enough of the normal myosin binding protein C is made. So there's an attempt to try to uh, treat that with nucleic acid therapy. And so an adenovirus associated 9 vector is used, which can target the heart relatively specifically and deliver wild type or normal myosin binding proteins C. cDNA, which is then translated into protein by the cardiomyocyte machinery. So we'll see if that helps to restore the balance of myosin binding protein C that's available to the heart muscle and improve disease. And there is a lot of interest in doing true genetic therapy, actually modifying the person's DNA. So this initial approach doesn't actually do anything to the patient's DNA. It's just introducing some extra um, normal sequences to be turned into protein. But to truly cure this genetic disease, you would, as you said, try to correct the underlying um, genetic change with new technologies, not necessarily the OG CRISPR, but there are newer technologies that are available now with base editing and prime editing that have greater specificity and some other technological advantages than CRISPR does. So this is a big ask and a big technological challenge that will need many more years of research to make it ready for trialing in people. But it's really exciting to think that we might be at a point that's in the not too distant future where we can actually start to um, manage these genetic conditions by actually correcting the underlying genetic cause.
As an extension to this, do you think there are any genetic disease modifying therapies which may decrease the risk of lethal arrhythmias in these patients?
Well, I think that's to be determined. Whether the the adenovirus myosin binding protein C approach will result in decreased ventricular arrhythmias. Remain to be determined. And similarly for any um, a gene correction technology. That's kind of down if, pretty far down the road to know.
And yes, I'm probably gonna just end with this question here, which is there a role for genetic testing in screening patients who may be at risk now that we have the advent of, I want to call it augmented intelligence and not artificial intelligence? I mean, you have these algorithms which are picking up patients who may be at risk for hypertrophic cardiomyopathy based on their 12-lead resting electrocardiogram. Do you see any role?
Yeah, well, I think that those kind of the AI assisted EKG algorithms are potentially a useful screening um, technology for situations like maybe pre-participation screening, where you have a lot of people that are potentially for the vast majority are going to be quite healthy. You're just trying to see if you can pick out those that might be at greater risk in a in an inexpensive, non-invasive, and efficient manner. So that there might be some role for them there. We know that it will um, um, result in downstream testing, of which the actual yield is TBD. Probably not super high. So there's going to be some healthcare utilization and cost with that, but it might be a way to try to help with kind of like larger screening efforts like that. But for genetic testing, you always want to start with somebody that has a definitive diagnosis of HCM. You don't want to use genetic testing as a way to try to figure out if somebody might have HCM or might be at risk for HCM, because it's just not that's not the um, that's not a good application of genetic testing. It's really genetic testing is there to help confirm a diagnosis and to like identify the potential etiology or potentially identify the etiology and to assist with family management, but it's not a screening test.
Yeah, no, that's fantastic. Well, thanks again for joining us on Parallax, and to our listeners, thanks for tuning in on another Monday. If you have any questions for myself or for Dr. Ho, do feel free to email them to us. You can also tag us on social media platforms like Instagram and LinkedIn um, and X. Do share your feedback with us. We take it seriously. And until other Monday, thank you for tuning in.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/parallax. Thanks for listening.